It is just a huge honor today to be podcast interviewing Mark Anthony Limosani. Are you married to Jennifer Lopez?
No, no, don't look at what you see on E-Entertainment. That's past news.
You're a different Mark Anthony, who received his D.M.D. degree from the University of Montreal in 2007. Since then, he completed a one-year multidisciplinary residency at the Queen Elizabeth Oral Health Center, a McGill University program. Following 1 year of private practice and many hours of continuing education, he then followed his dream and attended the specialty program in endodontics at Nova Southeastern University, where he's also received his master's degree in dental science. He won the Robert A. Uchin Endodontic Award for his presentation during Nova's Endodontic Alumni Day. Dr. Limosani has lectured locally and internationally on many topics in endodontics, including dental traumatology, the restoration of endodontically treated teeth, restoratively minded endodontics, diagnosis and treatment planning, and comb beam computed tomography, CBCT, used in endodontics. Thank you so much for coming on the show today, buddy.
Thanks for having me. I really appreciate you. I'm honored to be speaking with you. So this is great.
So your practice is in Aventura, Florida?
I actually live in Aventura. My practice is in Weston. It's a suburb of Fort Lauderdale, so to speak.
Oh, okay. Well, there's a thread on Dental's Town talking about the difference, how we were trained in endodontics 30 years ago versus today. What's hot and what's not in endodontics? What do you think is different today in endodontics than 10 years ago?
I mean, there's been so many changes in the field. The use of microscopes has made basically a specialty that was more tactically oriented to something that's much more visual, very dynamic. Now, use of ultrasonics, then came CBCT. There's just such a wide range of changes that occurred in the specialty. More recently, the more strategic dentin conservation approach, that's really the new wave, keeping things more conservative and focusing on salvaging more tooth structure.
I think I almost ought to start off with this first, before we even talk about endo. But one thing that scares me about endo, it seems like half the graduating class walks out of school. We just had 6,000 new American dentists minted 3 months ago, and another 6,000 are going to start dental school this week. And it seems like half the students who come out of dental school already hate endo. What would you say to someone who graduated and they already hate it?
I think you have to find what it is in dentistry that you enjoy doing. I like the minutiae of endodontics. I like the precision of it. I found a very good mentor that was up to date with all the technology, and I just pursued it and I really enjoyed the clinical practice. And I mean, that whole aspect of endo is something that I wasn't really familiar with straight out of dental school. So, I mean, if it's something that you hate, just, come to finding courses or finding mentors that are passionate about it, and soon enough you'll find a liking to it. I find that, endodontics is this branch of dentistry that has this whole different kind of concept with, the tactile aspect of it. So some people take a liking to it, other people hate it. It's one of those things.
Yeah, I always think you hate everything if you're losing at it and getting beat up by it. So
yeah.
if you really hate something, you need to do it until you master it, and then you might love it after you master it. This is Dentistry Uncensored, so I like to talk about all the controversial things. I don't want to talk about anything anyone agrees on. Let's go to a standard of care, because when you do a molar root canal and you're a general dentist, it's going to be judged by the standard of care, and that's going to be your local endodontist. Is microscopes and CBCTs, is that bordering on standard of care, or?
I would say with microscopes and CBCT, I mean, I would say to be able to practice at the highest level of proficiency in this day and age, both microscopes and CBCT are pretty much invaluable. That being said, there's a significant amount of time that was spent in dentistry in which these technologies did not exist, and root canal therapy still remained very successful. So I don't think it would be fair to practitioners to say that would be the standard of care, because, I mean, root canal therapy was practiced without those technologies. In my personal experience, in my practice, and at the level of care that I espouse to to provide, those technologies are indispensable. But I mean, I wouldn't say that, if every root canal had to be performed with both CBCT and microscopes, something that would be commonplace everywhere. So I'm a bit more realistic in my thoughts.
I'm really starting to have different views about whenever you talk to a rhinologist, an ear, nose, and throat, they're starting to tell me a lot that people who think they've had allergies for 10 or 20 years actually have a failing root canal leaking into their sinus. And I've seen videotapes of these as study club presentations. Do you think that if someone has an existing maxillary and root canal in the second bicuspid and the molars, that the health history should say, do you have sinus problems, and really start looking at it in a whole different way? Is this thing is something failing and chronically leaking in the sinus?
That's a brilliant question, and I do see maxillary sinusitis of dental origin quite frequently. I think that the key would be to create an inner working relationship between both root canal specialists and ENTs, or the dental community and the ENT community, to kind of get on the same page and create that dialogue, seeing as though there is so much of an interchange and that possibility being there. I think that it would be a question of kind of fostering that communication in study clubs and really kind of examining those relationships. I think a thorough medical history always, should be taken regardless of whether or not we're dealing with a maxillary sinus issue. But just to kind of open the minds of people to start thinking along that train of thought, I think is important and very pertinent.
I want to ask another controversial question. If you're a dentist like me, I have 7 restorations in my mouth, and they're all gold, because gold is perfect. It's soft, it's malleable, and the consumer wanted porcelain, so we went to PFM, but now it's all gone to zirconia, and some people are thinking, well, when you used to traumatically bite something, the weakest spot was the porcelain off the metal, and that would chip. But now that you've replaced the PFM with zirconia, that's not going to give. Some people are thinking that what's going to give is the endodontically treated tooth underneath it. Do you think zirconia will lead to more long-term root fractures than, say, porcelain fused to metal?
That's actually a great question. I would say those like for restorative failure would be the additional preparation that would be required to accommodate the material. So if zirconia would require a deep chamfer as opposed to more of a feather-edged type margin that was required in gold, more specifically on the lower second molar, then necessarily, that additional preparation could lead to tooth loss. From my perspective, and kind of speaking to this wave of endodontics that's moving towards more of a minimally invasive approach, I try and keep my access as conservative as possible. I try and limit the shaping of the canals in the coronal and mid-root portion, and I'm leveraging the new technology in metallurgy that allows pre-bending files before placing them in canals, and is more mindful of that danger zone in the middle and mid-root and coronal portion, coronal thirds of that root space. Switching from zirconia to from gold to zirconia in the lower second molar region, those are teeth that have more of a propensity of cracking, and if you're restoring those cases, I think that those teeth have more of a propensity to be restored in patients that suffer from bruxism, and they're due to some form of a parafunctional habit. So I think we're kind of segmenting a portion of the population that tends to have endodontic failures that are related to cracked teeth. So it's kind of a chicken and the egg, is it due to the material, or is it due to the case, the way it started?
When I got out of school 30 years ago in 1987, it was all hand files. And I looked at all the root canals that were prepped, shaped and cleaned 30 years ago to now. It seems like when rotary came out, especially when the 04 taper came out, it seems like the preparations 30 years ago were removed half as much tooth structure as it went to rotary. It seemed like when rotary came out, it was like switching from a table saw to a chainsaw. And,
Yep.
and then, there's just, I mean, you see it all the time when you take x-rays of new patients. I mean, these root canals, but you're saying that you start to see the pendulum swing back where people are starting to say yes. So what is too big of a taper? What is too big of a file? Do you think do you think filing out molar to an 04 taper is just too aggressive?
So I'm going to say that it would be more the constant O6 taper that would create that extra funneling. I think the inappropriate use of Gates glidens or piezo reamers really leads to that over preparation. I would say that, what happened is that shift in technology led clinicians to adapt their clinical technique to the technologies available. Meaning, if I have rotary instruments and I want to use them and I don't want to break them, then I have to overflare the canal to prevent them from breaking. Well, now that we have rotary files that that are heat treated, we definitely can do things a lot more conservatively. And I think that, any rotary system that is mindful of that paracervical dentin, that area within the mid-root or coronal aspect of the tooth, and keeping that area more sacred and using techniques to access the root canal system. Sorry about that. Techniques to access the root canal system that are much more conservative. That allows us to save teeth and save more dentin. And I can't be credited for this concept. I think there are people way before me, namely doctors John Cotomy and David Clark, that kind of were visionaries in starting that shift. And guys like me, younger guys, have kind of taken it on and really seen how far we could push the envelope with regard to that more conservative approach.
So, everybody wants to know, they're listening to you right now saying, well, you're an endodontist, you lecture internationally, what system do you use?
I primarily work with V-tapers. I've just come to the conclusion that their whole model is more driven on that minimally invasive, more conservation of root structure approach. And in the coronal third of the root and the mid-root aspect of the tooth, they do provide me shapes that are a lot more conservative. So I've gravitated towards that approach. In addition to that, they're heat treated. So for those reasons, I've espoused using that system. There are other systems that have that philosophy in mind, but that's what works well in my hands. I like the tactile feedback that I get from those files.
And what is that website? You said V-tapers?
Yeah, that's the through SS White V2 tapers.
Okay, it's SS White.
Yeah.
Okay, let me see. Oh, okay, there I go. And what's the SS stand for?
That's a good question. I don't know. Actually, can you enlighten me?
You don't know what the SS White, but you know what the V on the V taper stands for?
Because it's not a constant taper. So
the V taper is basically, it's not continuing the flare the whole way up the file.
Correct. So you have that more tapered approach in the apical third to prevent the extrusion of materials and allow for that vertical compaction of gutta percha. But in the mid-root and coronal portion, it's a lot more conservative. So that you have the best of both worlds.
So SS taper is if you follow me on Twitter, they're all commuting to work right now, so they can't take notes. So they follow me at Howard Farran, and I just retweeted at SS White 1844. I thought SS White was out of Colorado, but it says on their Twitter that they're Lakewood, New Jersey.
Interesting.
I wonder which one's correct. So do you use everything from SS White on this V-taper system? I mean, is that your files, your gutta percha, cement?
That's actually a great question. I mean, with regards to sealer, I use AH+. With regards to gutta percha, I sometimes use the SS White gutta percha. Generally speaking, I use non-standardized medium fine cones. As an endodontist, I've kind of molded my techniques to the cases. So because of the fact that I'm not getting these more standard, more cut and dry cases, I'm always having to kind of play with the systems and play with the different materials in order to accomplish my goals. So I do tend to use their products, but not exclusively in terms of the gutta percha. I do happen to use their products exclusively in terms of the files, the rotary files, but that just kind of fell that way.
So you're basically promoting more minimally invasive preps. So you don't want the flare to go all the way from the end of the file to the top, because then when you get up in the coronal third, it looks like it's been blown out with a Gates Glidden or something.
Exactly. I mean, I more specifically because I don't believe it's necessary. I don't believe it's necessary to remove all that additional tooth structure. And specifically because of the fact that, as you noticed, hand filing was a lot more conservative and teeth lasted. I mean, the whole concept, or, you know, and I don't credit myself, I credit John Cotomy, Dr. John Cotomy, to enlighten me on that, is if you look at the cases that tend to have that long-lasting appearance, most of them have very, very little, very conservative preparations. Those that don't go the distance, or those that end up in perio oral surgery offices to be extracted and replaced, tend to be the ones that are over-flared and that have lost a lot of tooth structure. So that's where that movement to take a more conservative approach really stemmed from.
And he's in Durango, John Cotomy, he's in Durango, Colorado, right?
Yeah, that's right.
Yeah, one of my classmates practices right across the street from him. He's an amazing person. So you said you use AH26. There's a lot of people asking on Dental Town about these new bioceramic sealers.
That's a great question. I do use BC Sealer I actually use BC Sealer and putty for surgical cases. I'll use it in cases of open apices, sometimes BC Sealer, sometimes MTA. That just using it from on every routine case, there's a big cost involved, and I haven't really seen the true benefit of adding that cost without necessarily seeing outcomes, like better outcomes, just because of a change in sealer. And I have seen instances where clinicians adopt a new material to fix a problem that really isn't broken, kind of like Resilon, and then you end up using a product for X number of cases, and you end up with obturation-based failures, and then you start questioning all of the cases that you did using that method. So I like being progressive in my approach, but I don't like changing what's not broken.
So MTA, that's the mineral trioxide aggregate developed by I can never say his name right, Dr.
Torabinijad.
Mohamed Torabinijad.
That's
D.M.D,
right.
MSD, PhD, Professor and Director of Advanced Specialty Educations at Endodontics, Loma Linda University. What is so funny about that is it's so expensive in a dental office, but it's just Portland cement when your pool guy comes. Is it pretty much Portland cement that your pool guy's using?
It's basically medical grade Portland cement. I mean, I know that there are some. I mean, there's some standards that you have to go through to be able to, place materials in the body and leave them in the body. So I can understand the rigor that into having to develop an endodontic material. But yeah, at its rawest form, it is basically Portland cement. And, God bless Dr. Torabinijad to have come up to that conclusion that you can use Portland cement in specific cases in endodontics.
Yeah, that is amazing how that, and it's the same thing with, there's all these people who want to do a lot of stuff with super glue, but you can't invest $1 million going through the FDA program when you're going to have something that you can go buy at Walmart for 99 cents. It's kind of it's tough that way. I want to ask you another question. You can kind of divide all root canal providers into either apical barbarians, where they want to get patency and a puff of sealer at the end, and then the other side is the pulp lovers who want to leave a 0.5 millimeter of tissue at the end. Would you say you're an apical barbarian or a pulp lover?
I would say, I mean, look, the way I see it is, if I'm not to the apex, and if I can't go beyond the apex, then I don't know where I am. So I use electronic apex locators exclusively in order to determine my length. And if I'm not out, then I don't know where I am. So I like to I basically fit my cone, and it depends. I'll fit my cone to 0, 0, right at EAL, apex locator, right there, if I have a very conservative preparation. If I'm dealing with a distal canal, palatal canal, and it's a little bit on the wider side, then I'll fit the cone to like 0.5, but I don't tend to like my cases to look short. That's my, the aesthetics of endodontics. I would much prefer my cases to be to length, and a little puff doesn't bother me.
When you lecture on dental traumatology, what does that all encompass?
That is such a broad topic. There's so much to talk about. I've got kids that come to the office, and it's from an avulsion to a pogo stick action that lasts 4 intrusions to, a complicated crown fracture. It's everything under the sun. But the impressive thing is so much of it has major implications in that child's future. You're talking about going to high school with a missing tooth or a flipper, or it has a very big implication on the kid's ego. And not to mention the expense that they're going to have to incur later on in life to be able to cosmetically and functionally repair that the defect that's created. So I think that, having more knowledge in terms of how to manage trauma is crucial, and it actually has a very big impact in these kids' lives.
What is the success rate these days of a reimplantation when a kid avulses a permanent anterior tooth?
It really depends on how fast it was reimplanted in the mouth. And if it wasn't reimplanted in the mouth within 30 minutes, what medium was it stored in? Was it stored in milk, saliva, water, orange juice? That all has a huge impact. If it was stored in dirt, or if it wasn't reimplanted in a reasonable time, that if the apex is open, then you probably have a better chance of having a better long-term prognosis. But there's so many variables that have a great influence on the success rate of a reimplanted tooth. But in any event, you do everything you can to try and save the tooth. And if in certain instances you can't save it, then you move on to other options.
You got a very young audience you're talking to right now. There's, most of these, probably a quarter of them are in dental school. The rest are almost all under 30. How should she wrap her mind around a tooth if she can't decide to salvage, root canal, build up crown versus extraction, implant?
I think ultimately it's the patient's decision. I think that our goal is to really educate the patient of their options. I think that, there is no standard, root canal post-core crown. It really depends on how much tooth structure is left, what else is going on in the mouth, what's the occlusion like, what are the patient's values. To extract a tooth and not replace it, I think is a shame. I think it has major orthodontic implications. I really look at the patient, provide them my honest opinion, and then ultimately they make the decision. But the amount of tooth structure remaining and the patient's desire to save their teeth is high up in the discussion.
Well, I personally, I'm so glad to have you on the show. I personally think they're fed a lot of information from implant manufacturers that's not true about their success rate, and then compare it to a less rosier picture of a retreat. How is she supposed to, you keep hearing these numbers from implant companies that have like a 98.9 success rate or a 99.4, and it's just not true.
Yeah, I would say that one thing that's never considered is the strategic position of that specific tooth in the overall scheme. Meaning, if that patient is moving towards partial or total edentulosum, and you go stick an implant in, let's say, the premolar region, when in fact, when it comes to an all-on-4 case, or it comes to a more advanced prosthetic treatment or rehabilitation, it would have been more appropriate to have it in the molar position. You got to take that into consideration. So I think that, saving teeth within reason, if the patient's aware, willing to commit the time, money, and effort into doing so, should not be a lost art. I think that the more we remove teeth prematurely, the more we lose our ability to know how to save teeth. And that doesn't just go for endodontics. It goes across especially periodontics and restorative dentistry. If the young dentist isn't being taught how to save a tooth, then obviously, if all you have is a hammer, then everything looks like a nail. So I think that they should be taught on, certain techniques to be able to save teeth like they were done, in the past when implants were not as commonplace.
there are approximately 4,000 endodontists in the United States. What percent of their 4,000 endodontists in the United States, what percent of their cases do you think are retreats versus initial treatment?
That is such a great question. I really think it depends on it depends on the location. In more of a major metropolitan suburban area, I would say that that's probably more of a higher range, maybe in the 30, 40. I mean, there's some practices that are pretty much exclusively retreatment based. There's some practices that are exclusively surgical retreatments or surgical approaches. But I think the more you move out into more in areas where there's more quote unquote sophisticated dentistry, then the retreatment is going to be a part of the treatment plan. In other areas, that might not be as much of an option. But I mean, speaking from my practice's perspective,
I always like to spot controversy in dentistry, and it seems like every single dentist thinks their composites last longer than amalgam. But then when you look at the big picture of the data, the amalgams last twice as long as the composites. But when you start talking to them, they say, well, endodontists love amalgams because they fracture the teeth. And it's like, what do you think is more likely to drive an MOD restoration and a molar to an endodontist someday needing a root canal? An MOD amalgam or an MOD composite?
That's a great question. You know, I really think that it has the patient has the biggest influence on that. It depends on what their habits are, depends on where their hygiene is, and it depends on, parafunctional habits and what their habits are. I think that if they have if they have any propensity to bruxism or any parafunctional habit, or their occlusion is more hostile, then amalgam could lead to more fracturing and so on and so forth. However, if they have a mouth that's more hostile in terms of caries, then they're more prone to recurrent caries, or they're a hypersalivator, and just execution of treatment on them is a lot more complex, then composites are probably not the more appropriate material. So, man, it depends on the patient. It's you have to take a patient-centered approach. We work in a mechanical world, but that's constantly changing. It's like you're playing football, but one day it's snowing, one day it's raining, one day. So what shoes are you going to wear? Well, you're going to wear the shoes that are appropriate for that day. That's the way dentistry works, in my opinion.
Yeah, it is surprising to me, though. I think at least half the dentists in the United States, they don't even have amalgam in their armamentarium.
That's crazy.
Anymore. And do you still have it in your armamentarium?
Absolutely. If I'm dealing with any case that's in close proximity to the alveolar, to the marginal ridge, any instance where it would be a larger core buildup, and I know that a crown is planned, I think an amalgam is a great material. I wouldn't see how. I think that a lot of teeth would end up extracted prematurely if amalgam is not being used in some cases. Would I say that composite has brought a whole nother facet, a much more conservative approach? We can be a little bit more proactive and still remain conservative, absolutely. But I do think that amalgam still has its place.
Okay, I got another good controversial one for you. There's a lot of dentists that I've heard say over breakfast, lunch, or dinner over the years, or on Dental Town, saying the only purpose of a post is to fracture the tooth.
Not true. So I think that in instances, in anterior teeth, in premolar teeth, more specifically, what are your choices to obturate the root, the mid-root or the mid to apical portion of the root canal system? Gutta percha, filling it with dual cure composite resin, filling it with some other bioceramic material, or placing some form of a material that mimics the flexion of the natural root, and that would be a fiber post. So I'm all for placing fiber posts, so long as it doesn't incur much more additional preparation to the root canal space. So I mean, I'm thinking, even when performing root canal therapy through a crown, a premolar, an anterior tooth, it's very appropriate to place fiber posts, passively fitting fiber posts, with no additional preparation of the root structure.
What do you think is more predictable? And I know these are general questions. I know these questions are so hard to answer because it depends on the specific case. but I got to talk generalizations. What do you think
Sure.
is more predictable? A pulp cap if you run into the pulp and sealing it right there, or going through and doing the whole root canal and sealing it at the apex? How should you decide to pulp cap or endodontic treatment?
So I would say, I'm going to be I'm going to be reverting to this again and again, but it really depends on the lifestyle of the patient, their age. I think a younger patient, definitely if the apices are open, we're moving more towards any form of pulp preservation. And even with regards to teens and younger patients, I think it would be more valuable to use more biocompatible materials in order to pulp to cap the pulp. As we get older in age, the value of attempting to save the pulp becomes low. Value of preventing a very uncomfortable and unpredictable experience goes up. So, for instance, if I have, let's say, a 60-year-old male and they've just had a pulp cap on tooth number 30, well, what is the consequence of them going through pulpitis? Missed work. They're on they have to get a flight home. They're in the middle of God knows where they have to go get a root canal by someone if they may or may not be qualified. So that's a very negative effect of a pulpitis in that case. Now, if you have a 13-year-old kid that has a pulp cap, and that pulp cap lasts another 6 years till they're 19 years old, they're right about to go to college, then they're much more mature. And in addition to that, the pulp has had time to recede. So it's about pulp chamber in order to address the root canal system. You're able to do that a lot more conservatively as well. So it really depends on the age of the patient and their lifestyle. That's my opinion. But I do think pulp caps are appropriate in certain instances, and using the appropriate materials is also very important.
Well, what is your go-to pulp cap material?
MTA in the posterior, and if I'm working in the anterior, we're going to go for some form of bioceramic material, either BC root repair material or biodentin.
No, when you do use MTA for a pulp cap, do you have your own personal pool cleaner man deliver you a fresh batch of Porter cement?
No, I actually buy it from the manufacturer.
Oh.
I get the legit ProRoot MTA. Especially when dealing with such a material-sensitive procedure, I really want to make sure that I'm using the gold standard, I'm using the best. Because if it ends up failing, I want to know that I gave it the best shot.
I was just kidding. That was just a dumb joke.
It's a good one. It's a good one.
I want to ask you some other very controversial question. I mean, I don't know if you have seen this or not, but there are a lot of dentists in the United States that after every single root canal they've ever done, they give them 28 tabs of Pen BK, 40 tabs of Pen BK, 3 or 4 tabs a day for 7 to 10 days. I mean, have you seen this, or is this just my old friends?
I know that does tend to be, I mean, in my community, I wouldn't say that that's routine, but I have heard about that. I mean, I think that it's just a question of, previous habits. I don't think it's necessary. I think it could actually be harmful in some instances. I have had patients that an antibiotic is prescribed, they end up with major, diarrhea or any type of GI issue, and then you're really regretting, or questioning if that was really necessary. So, I mean, that's not commonplace in my practice. But I wouldn't be able to tell you all the rest of the practices in my community, what it is that they do.
So the same question, when I got out of school 30 years ago, the media was coming down hard on doctors, oncologists, that you're not prescribing enough pain med. There's people that are dying in chemotherapy and they're in pain, and you did root canals and you pulled her, and there's this big push to get all these conservative doctors and dentists and physicians to prescribe more opioids. Now the pendulum's all the way to the other side. Now there's a lot of people saying, the problem is, so many endodontists and dentists and oral surgeons are prescribing all these Vicodins, and they call out oral surgeons by name in these articles in big newspapers. So the question is, how do you get your mind around the opioids? Do you use opioids?
I would say I use them very, very, very rarely. I would say that most often with a good combination of ibuprofen and Tylenol, That takes care of most postoperative sensitivity. In many instances, when I'm dealing with a case of periapical periodontitis, meaning tap on the tooth and it hurts like crazy, or the patient's complaining of a deep gnawing ache, and when they touch the tooth, it hurts like crazy after procedure was done, I've come to the conclusion that it's more appropriate to prescribe some form of a steroidal anti-inflammatory, assuming their medical history allows narcotic. I've found that to be much more effective in providing them relief rather than narcotics. I do sometimes prescribe narcotics, but it's definitely not routinely.
When you are doing your retreats, what percent of these are failed because they weren't done correctly by the general dentist? And when the general dentist does a root canal and it fails later on, what are the usual mistakes? Is it mostly missed anatomy, or not getting to the apex, or what would you say is the major mistakes?
I would definitely say it's a combination. I mean, what I see most frequently is definitely missed anatomy. Missed MB2 is something that I see very, very frequently. I mean, I'd go so far as to say is, there's some instances that, mid-mesial canals, or a canal that's located in between the two mesial roots of lower molars, can lead to failures. I've had instances where a tooth was treated and retreated and that canal was still missed. And then upon my third revised treatment, I find it, and there's resolution of, or bone fill. So it really depends, but that tends to be the most common. Missed anatomy tends to be, I would say, the most common when I'm dealing with retreatments.
Where would on the top 5 reasons, where would a broken file come in? Is that also very common, or is that less common than it was 10 years ago?
So I would say it's less common. I would say that I don't deal with separated instruments as frequently as I possibly would have expected when graduating. I would say that most often those cases, if it needs to be addressed in the mid-root or coronal aspect, I'll attempt to bypass or retrieve it non-surgically. If we're into the apical third, I'd much rather proceed with a surgical approach, assuming anatomy is appropriate. But again, it goes down to how much tooth structure is going to be remaining after your attempt of removing the separated instrument, and that's how I make my decision. It's about the amount of tooth structure left. Biology is important, but I think we deal with a lot more of a mechanical. We're in much more of a mechanical or a biomechanical field than we are in a strictly biological field. And we need to kind of embrace that aspect of what we do.
We're supposed to be patient-centered and not doctor-centered. It was supposed to be all about the patient, not about the dentist. And I see a lot of dentists sending a patient to the endodontist saying, you do the root canal, but I want to do the buildup and obviously the crown. But, I mean, when you look at saliva with 1 billion bacteria, microorganisms, fungus, viruses, and parasites per cc, which is the volume of a nickel, gosh, don't you think that having them leave your office temporized and maybe not getting back into the office for a month, I mean, do you really think that's the best deal? Don't you think it would be better if the endodontist always did the buildup?
That's a great question. I mean, some of my referrals would prefer me to do the buildup on all cases. Some referrals are a little bit more selective, and they would prefer to do the buildup. In those cases, what I tend to do is place an orifice barrier. I'll place 1.5 millimeters of resin on the floor of the tooth, and then restore with some form of temporary restoration. In some cases, I'll have an open discussion with the referral and say, listen, this is a pretty difficult restorative case, and I'm not so confident that we'll be able to maintain that sterility during a temporization phase. Would you be opposed to me placing the core? And very often they're okay with that. I think it's just a question of having that open discussion rather than making a blanket statement. I'm placing all restorative at all costs. I think it needs to be discussed, and then that relationship is then molded into what ends up being best for the patient.
let's say she just took an x-ray of this tooth and she doesn't have a CBCT and she can't tell if it's internal or external resorption. What would you tell her?
I would say, I mean, you know, the value of CBCT when it comes to resorption is tremendous. I think that, you know, taking shift shots really only gives us an approximation. We don't truly know exactly the extent of the resorption defect when we're not using CBCT. You know, in my practice, I mean, CBCT is a must when it comes to resorptions. I really do want to know if this is going to be something that's predictable, and if I'm going to attempt it, you know, what's going to be the approach, non-surgical, surgical, what materials am I thinking that I'm going to be using? So with regards to resorption, that's my take on things.
You know, it seems like whenever you see two general dentists talking about endo, they only talk about, well, what system do you use and what do you obturate with? They always talk about obturation. And even if they ask about files, I mean, the file, I mean, most of the stuff I read is that the files and everything maybe gets out 2/3 of what you need to remove, and the other 1/3 is irrigation and etc. Why do you think that it's always focused on how you obturate, what you put back in, instead of what you take back out? And what advice would you give them on irrigations and new technologies to get the? Do you agree it's about 40% that you probably only remove 60% mechanically?
Absolutely. I would say, well, first off, to answer your question with regards to obturation, I think that the reason why so much focus is on obturation is because that's the final result that you end up looking at. So it's like, you know, if you look at an artist and you look at his painting, you're going to say, well, you know, what paint did you use? How did you recreate this? Because of the end result. You don't go into the brush and the nuance. So I think that, you know, obturation is a reflection of instrumentation. I think that, you know, thorough irrigation throughout the procedure, constant irrigation is paramount. And I think that addressing all the anatomy also ends up giving you the look, that endodontist look. It just looks more denser because there's more of that internal portion of the tooth that's filled. And what I would, you know, my best piece of advice is use enhanced magnification and take more advanced continuing education to be able to find all the anatomy and address it. And once you do that, you know, the rest comes with it. That's my opinion.
And what is your go-to irrigation?
I use sodium hypochlorite throughout the entire procedure.
What strength though? I mean, straight out of the bottle, or do you dilute it?
I dilute it 50% because now straight out of the bottle is at 7 to 8%. I prefer my solution to be a 4% solution, so I'll dilute it 50%. And 17% EDTA to remove the smear layer, followed by a sodium hypochlorite wash, followed by a 90% isopropyl alcohol to dry the canals at the end. Microsuction to remove most of the moisture, then paper point wicking, and then we're ready to fill. In retreatment cases, I've been adopting a 2% chlorhexidine solution right before I place calcium hydroxide after the first visit. So those are the main irrigation techniques that I use.
That's very interesting. Do you use any ultrasonic devices in the irrigation to try to get the irrigation into more lateral canals? Or, I mean, you see some of these CBCT images of these teeth, and I mean, it almost looks like a fern is growing. You know,
yeah.
It's not like a tree stump. You know. So, do you use any ultrasonic agitation? Do you think that is worth it, or does that work better, getting in all those nooks and crannies?
So typically what I use is I'll pump a gutta percha cone. Some studies have shown that there's no major difference between pumping your master cone versus sonic or ultrasonic activation. From what I've noticed, for instance, when there's isthmus tissue, or when we're dealing with a C-shaped canal, or one of those mesial roots of lower molars, or two canals that join, very important to constantly irrigate and flush out, such as ultrasonic or sonic activation are helpful. But I don't think that replaces finding all the anatomy and being very meticulous about attempting to address it all with small pre-curved hand files.
Another question that prominently comes up on Dental Town with very young dentists is they hear a lot of some dentists say, I do all my root canals in one appointment. Then other people say, well, sometimes you should do it in 2 appointments. Then some people say that, if it has a periapical radiolucency, you shouldn't one-step it. How does she get her mind around a 1-step or a 2-step?
That's actually a great question. I would say that, with regards to symptomatic cases that are not related to pulpitis, I'm much more inclined to go with a 2-step model. That just gives you more comfort to know that the patient is then comfortable when we choose to obturate the root canal system. That being said, there are some instances where I'll opt for a 1-visit approach, but I like the security of a 2-visit model. I like the ability to be able to ensure that the patient is now comfortable. From a convenience perspective, there are some instances that I'll make an exception. It takes me a little bit out of my comfort zone, but I do understand that some patients have certain needs, and I'll opt for that. For instance, if I'm doing a case under and we're understanding that he'll have to go under general anesthesia in a hospital setting in order to be able to address his tooth clinically again, in those cases, I'll do everything in my power to finish it in 1 visit. But de facto, I would prefer the security of a 2-visit model.
I love how you're talking about the final restoration, that try to use a final restoration that doesn't involve so much reduction. I mean, not only not carrying out the taper all the way up, but then not putting a final restoration. I mean, some of these cases you see, by the time they flare out at 06 and then put a 2-millimeter shoulder around, it's like, which also leads to my other question. A lot of these young ladies are working with their dad, who says every root canal tooth should be crowned, and then they're doing a lower anterior, and by the time you get done prepping a lower incisor for a crown, it looks like a grain of rice. And so we filed the entire tooth down to a grain of rice to save it. What do you think of these one-liners like every root canal tooth has to have a crown?
So the studies that were based on the Farrell effect and based on crowning teeth after endodontic therapy were really examining teeth that have forces that are that are compressive forces. So if you're dealing with a tooth like a molar or even a premolar that's dealing with compressive forces, then you are more moved to recommend full cuspal coverage. When we're dealing with an anterior tooth that's dealing with more shearing forces, removing more tooth structure in order to place other types of materials, and more specifically weakening the tooth at the neck, is actually that definitely does not strengthen the tooth. If anything, it would give it more propensity to breaking in the future. So I would say with premolars and molars, it may be more appropriate to consider some form of cuspal coverage, assuming you're more conservative with your axial reduction. And when it comes to anteriors, and in some instances premolars, and many times crowns are not an appropriate form of breast.
So another thing that freaks people out early in their career is the tooth is symptomatic. They got to do a root canal. They take out this big old MOD amalgam that's been in there for 40 years, and there's a black line on the floor. And they're just like, okay, what does this mean? To treat or to extract?
That's a great question. I'll say that CBCT has provided us a lot of very good insight when it comes to those cases, not to be able to see the crack specifically, but to examine findings that may be correlated to bone loss patterns that would lead us to believe that the attachment is significantly involved. And even at that, I always leave the decision to the patient. And the way I say it is, Mrs. Jones, if you come back to the office, come to the conclusion that the crack has progressed, and now that tooth that you spend the time, money, and effort on a root canal, post-core, and a crown, or a root canal and a crown has to come out, would you feel satisfied that you did everything that you could to try and save your tooth, or would you feel regretful and upset at me? If you believe that you'd feel regretful, then the most definitive option, because you can't go back, is to remove. And we'll do everything in our possibility to be able to put the cards on your side. The crack is just more of an unpredictable, just gives a much more unpredictable approach. That being said, not all cracks are the same. I would say that if I would see a crack that's not extending down the root canal system, there would be a better prognosis associated with it. I would say that if we have a crack that's going further, the prognosis is more compromised. And if we're choosing to save it, definitely want to consider totally flat occlusion, no excursive contacts whatsoever, and hope that the patient has a more favorable occlusion to be able to maintain that tooth.
When you're almost done with your root canal, and it's a molar, but one of the canals keeps bleeding, what do you use to stop the bleeding, and at what point does that bleeding say to you, I'm going to temporize this and wait, and how long would that time period be? I know that was 20 questions in one, but hopefully...
No, that's a fantastic question. In some instances where I really, we want to finish the case for whatever reason, in some instances placing a little bit of ferric sulfate on a paper point and placing it in the canal, and then obturating the other canals is enough. In some instances, you need to increase a little bit of the apical size of that preparation to remove a little bit more of the pulp tissue. I'm noticing that, in vital cases with younger patients, I'm more inclined to go to a 2-visit model because they're more ovoid in nature, and I'm finding that the use of calcium hydroxide really helps me, at that second visit, get that nice dry canal where I'm able to obturate and not have any question with regards to weeping or anything of that nature. I don't want there to be questions.
Back to obturation, I think that we have to do techniques that can be retreated. I mean, they're retreatable. It's kind of it makes it difficult on the long term if you do something and you can't retreat. Do you think some obturation techniques make it harder to retreat? I mean, you see a lot of gutta perches on a cone that leave gutta perch on carriers. Are there any obturation techniques where, as an endodontist, you would say that really makes it a lot harder to retreat and shouldn't be used?
I would say, Howard, that the difficulty in retreatment has much more to do with the instrumentation that was performed. The canal was under-instrumented and a thermophil or some form of carrier-based obturation was placed. Then those cases tend to be a little bit more challenging. I would say that if proper cleaning and shaping was performed and that method of obturation was used, those cases are actually not that difficult to remove the carriers from. You just have to have the right technique. I tend to use a headstrum that's wound in, and I'll use a fulcrum or some form of technique to be able to remove that carrier. That being said, instrumentation creates the most frustrations when it comes to retreatment. Ledges, blockages, or under-instrumentation and placement of obturation materials that are very hard, such as, let's say, resin-based paste, makes the obturation much more difficult than, a blanket statement of thermophil's hell. I feel like carrier-based obturations are hell in cases where the instrumentation was inappropriate.
Couple more questions. You've been so I can't believe I got you on your day off to talk to me for an hour, but I just got a couple more questions. Sometimes she knows the toothache is in this quadrant, but she's just not sure. She's got it narrowed down to 2 teeth, but she's just not sure. What do you advise in those situations when you're not 100% sure because they're in so much pain?
As an endodontist or as a general practitioner?
Well, what advice would you give the general practitioner?
Well, it's very, and this is just my perspective. From a preservation of practice perspective, getting the wrong tooth from a general practitioner's perspective is a lot more harmful, I believe, than an endodontist. Because as the endodontist, you've gone through all the tests, you have that advanced training in endodontics, and if you went through the discussion with the patient, you told the patient that there was some uncertainty, and we've made that commitment, and it ends up being the wrong tooth, I feel that the patient has less remorse, knowing that they went to a specialist, rather than having the general dentist having to make up for that. I just feel like that has more negative consequences on a practitioner's practice when they make that call. So that's really my perspective. If you're not 100% certain, and it may sound self-interested being an endodontist to say that, but really looking at a disgruntled patient is really the worst thing that you can have for your practice. So knowing what the patient knowing that you did everything in your capacity to do right by them, I think is invaluable. So for that reason, I think a referral to an endodontist when you're not 100% certain is with that exact for that exact reason.
One of the biggest differences between your generation and my generation, I'm old enough to be your dad. I'm 55.
Okay,
When
almost.
I was well, I was born Catholic in Kansas. They started having them at 16, so I'm definitely old enough to be. But you know, the baby boomers, when they went to the dentist, you know, you would say, you know, 30 years ago, you would give the patient the recommendation. They'd just say, well, you're the doctor. And you know, and they
Yep.
were just more authority. I mean, like you look at the Ten Commandments. The first three is you know, obey God, don't change His name, obey. You know, the fourth one's
Your
honor your
dentist.
parents. But now the millennials are like, well, so what? You're an endodontist. I just spent 15 minutes on Google, and I know as much as you do. And we're getting a lot of questions where, I mean, if you go to beatcancer.org, I mean, they say the most common cause of all cancers is root canal filled teeth and cavitation sites. And until a patient gets rid of the root canal teeth, and I mean, you're hearing this. I mean, there's the internet started out as to spread all this information to the masses, but what it's turned into is spreading massive misinformation to the mass.
Misinformation.
And so, what do you do when what do you do when a patient comes in and says, I don't want a root canal, or I want my root canal teeth pulled because, and they show you all these Google articles, endodontics linked to cancer. What verbiage, or how do you approach that crazy topic?
So I'm going to say this. There are a lot of components to your question, so I want to address them each separately. For one thing, with regards to the millennials, or the way business is done in this day and age, or the way interactions are done between us humans in this day and age, transparency is key. With any business, all while certain practices spread like wildfire. It's of utmost importance to be honest and truthful about why we're making our recommendations and give as much adjunct information as possible. Now, with regards to the link between root canal therapy and all types of different illnesses, there is literature out there that disproves that. If we were to think about it, if many causes of death were actually related to root canals, then it would be more likely that practice would no longer be provided, or that would no longer be a service that would be provided to people in general. So I reason through them. I don't disparage them. I encourage them to provide me with the information that they brought that brought this thought process to their attention. But I think it's just a question of being very honest and transparent and saying, you know, you can choose to remove your tooth. There are consequences to removing your tooth. There are consequences to removing many teeth. And the potential consequences that you have that are very clear may not be so beneficial with you compared to the potential consequences that are not really founded based on having root canal and the potential, health risks associated with that. So, I mean, I'm just very honest and open, and if they appreciate my approach, then they'll listen to me, and if they don't, then they won't.
Well, that's good advice. I still think one of the hardest aspects of dentistry is dealing with the complicated patient's mind.
Hey guys, so sorry we got disconnected. Howard, I really want to thank you for this interview. I hope I gave you guys some good insights about the latest and newest in endodontics, at least from my perspective. If you guys have any questions, don't hesitate to hit me up either on Facebook, on Twitter, Instagram, or check out my dental group, the Dental Network. More than happy to have you guys over and discuss endo. Thank you so much. I really appreciate it, and you guys take care.